طيب في الناحيه الثانيه ablation when compared to medical treatment as a first line treatment عندنا 6 randomized trial 6 large randomized trial anti-arrhythmic medications versus ablation كلهم معروضين
مختلف عنه في الليت ستيجز. في الاول القصه بتبقى mainly contributed by triggers the pulmonary vein في حاله atrial fibrillation، لكن as the AF progresses ويتحول من paroxysmal ل persistent substrate contribution بيبدا يبان whether ب non modifiable risk factors او modifiable risk factors او AF induced substrate نفسها. AF begets AF الالكتريكال والستراكشر ريموديلنج اللي بيحصل. وانس ان يبقى في substrate involvement contributing للاتريال fibrillation الكنترول بالpulmonary vein isolation بيبقى اوحش. suggesting ان ال earlier is better. ده باين في ال early studies تاني اللي بتcompare ablation early ablation في ال paroxysmal versus early ablation في ال persistent. once ان انت تخش persistent الخط الاحمر هو ال outcome in persistent atrial fibrillation، الخط الازرق هو ال paroxysmal atrial fibrillation. ولو انت بدأت as early as you can still النتائج مع ال persistent اوحش من ال paroxysmal علشان الفاكتورز اللي احنا قلناها قبل كده. مش كده وبس، ده time from diagnosis ل offering ablation كل ما بيزيد كل ما في risks بتزيد other than response للablation. بمعنى ان in this study once the time from diagnosis to randomization to ablation increases from almost 1 year to 3 years to even more than this, the risk of stroke with transient ischemic attack increases, the risk of heart failure, hospitalization and admission increases. So the earlier there is constant message that the earlier the better. طيب هل ده معناه ان احنا we should wait ان احنا ندي medical treatment وبعد كده نعمل ablation؟ guidelines بتقول كده، بس maybe احنا بنتحرك حاليا في اتجاه ان احنا ندي فرصة اكتر للابليشن as first line treatment. طيب السؤال ده تحديدا الابليشن as first line treatment ده بيتسأل في الليتريتشر وبيتعمل عليه studies من 2005 وفي early studies من 2005 2012 2014 الرافت والمانترا باف والرافت 2 كلهم addressed this question. بس كان الابليشن tools والتكنولوجي at that time ما هياش as developed as the ones we have now. والملحوظ ان كلهم كانوا two small studies كلهم فيهم percent of crossover من medical treatment لابليشن. endpoints ما كانتش blinded قوي والابليشن ما كانش بنفس التكنولوجي اللي احنا ماشيين فيها دلوقتي. وحتى ساعة الستاديز اللي بينت improvement فما بينتش improvement كبير قوي. freedom from any atrial arrhythmia actually was missed في مانترا AF. لو حضرتك شايف الاودز ريشيو كيرف كروس الميد لاين في المانترا suggesting ان ممكن ما يكونش فيه benefit للايرلي ابليشن في المانترا اي اف. ولو حطينا السيمتوماتيك بس المانترا والراف 2 الاثنين did not make البرايمري اند بوينتس بتاعتهم suggesting ان ممكن من الايرلي ترايلز ما يكونش الفيرست لاين تريتمنت از ذا بيست اوبشن. ولكن اما عملنا ترايلز بتكنولوجيز جديده بكنترول سامبل اكتر بفولو اب احسن الدنيا اتغيرت شويه. الايرلي اي اف ترايل دي كانت ترايل بدات بدري بس اكشولي لسه ببلشت 21 300 عيان 150 فيرست لاين كرايو ابليشن فيرسس 150 ميديكال تريتمنت. كان فيها نقطتين قويين جدا. واحد الفولو اب كان كله بامبلانتابل لوب ريكوردرز، كل العيانين ركبوا لوب وبالتالي مفيش عيان هيجي له اف مش هيتشاف اوكي ايا كان سيمتوماتيك او اسيمتوماتيك، عكس الترايلز اللي بتعمل بيريودك اي سي جي مونيتورنج او هولتر. الحاجه الثانيه القويه ان هم عملوا فيري ريجرس بروتوكول فور اسكاليشن اوف ميديكال تريتمنت. مش مجرد ان انت بتدي ميديكال تريتمنت وتقول العيان ده خلاص خد بروبافينون او خد ريتمونون. اكشلي كان عندهم بروتوكول فور اسكاليتنج اكوردنج تو ذا ريسبونس. بالتالي لو خد دواء وما جابش نتيجه they would increase the dose. if ما جابش نتيجه they would add another dose. they would add up to 3 antiarrhythmic medications until they control the atrial fibrillation by the device they implanted اللي هو الريفيل لينك. الابليشن بارامترز ما كانتش فاريبل على الجنرال براكتس. والاند بوينت كان واضح جدا ان الفيرست لاين كرايو ابليشن فرق جدا عن الانتي اريثميك ميديكيشن فريدم as first line EF ablation فرق. مش غريبة شوية، بس دايما الكونسيرن في الحالات اللي زي كده اللي هو يقول طب what about the risk. طبعا الفيرست لاين دوت فرق سواء symptomatic او asymptomatic، بس والاي اف بيردن والكواليتي اوف لايف كل الحاجات دي اتحسنت. بس سؤال، انت مدي aggressive protocol for anti-arrhythmic medications وبادئ very early ablation، هتعمل ايه في الريسك؟ هل في ريسك بان زياده في الابليشن فيرسس ميديكال تريتمنت؟ الحقيقه ان السيريس ادفيرس ايفنتس ان ذس ترايل ما كانتش فارقه خالص ما بين الابليشن جروب والانتي اريثميك جروبس، ودي حاجه يعني كريدت لسه تو بي سين لسه في الريل لايف شكلها عامل ازاي. ولكن اكشولي السيريس ايفنت كان في وان مور سيريس ايفنت في الميديكال تريتمنت جروب عن الابليشن جروب، والاثنين ستاتستيكال ما كانش فيهم فرق. ومن الميديكال ومن الكومبليكيشنز اللي حصلت في الابليشن جروب الثري فرينك نيرف انجري دول ريفرسبل كلهم ات 1 مانث، ومفيش حد جاله persistent phrenic nerve palsy. حتى when you consider adding الماينر complications still ما كانش فيه statistical difference ما بين التو جروبس، والاثنين كانوا comparable. نفس الحكايه اللي اتعملت في الايرلي اي اف ترايل اتعملت في تو اذر ترايلز بقى وبعدها الستوب اي اف وكرايو فيرست ترايلز، كلهم كرايو ابليشن فيرسس انتي اريثميك ميديكيشنز اتعملوا في different parts of the world. الستوب اي اف كانت mainly في امريكا، الكرايو فيرست كانت في اوروبا برازيل واستراليا. كلهم نفس البروتوكول، سامبل اصغر شويه، كلهم الفيرست اند بوينت بتاعهم كان الفريدم اوف اتريال فيبريليشن، وكلهم they met this end point الابليشن as a first line احسن من الانتي اريثميك ميديكيشن في البريفنشن اوف ريكارنس. المونيتورنج كان مختلف شويه، علشان كده الابسوليوت نمبرز كانت مختلفه، ما حدش فيهم كان في اي ال ار غير الايرلي اي اف، ولكن الريسكس والامبروفمنت كان كونسيستنت يت. السيمتوماتيك والاسيمتوماتيك ستيل ميت في الابليشن جروب، والادفيرس ايفنت تاني ده دايما كونسيرن من الانيشيشن اوف ابليشن بدري، ما كانش في فرق ما بينهم في الثلاثه ترايلز. مور اوفر الكوست اناليسيس ورى ان انت لما تعمل الابليشن early when you think of this on the long run by prevention of cost of medical treatment and side effects and hospitalization for atrial fibrillation actually ولقوا ان الابليشن ارخص من الميديكال treatment on the long run، والفايندنج دي كانت consistent في 3 trials considering اليوتيلايزيشن اللي بيحصل. وبالتالي in conclusion ان الايرلي اي اف والستوب والكرايو فيرست trials كلهم resulted in significantly less arrhythmia recurrence، كلهم showed no signal of harm or any safety analysis، و although ان هم ما كانوش powered for secondary endpoint لكن كلهم وروا ان في significant reduction في الهيلث كير utilization واليوز والهيلث كير hospitalization. شكرا جزيلا يا فندم.
استكمالا لكلام الدكتور احمد عن الايفيب ابليشن، التوك بتاعي عن النيو موداليتيز ان ايفيب ابليشن. خلاص احنا متفقين ان الابليشن از بيتر ذان ميديكال تريتمنت، فبنتكلم عن الموداليتيز ايه اللي ممكن نستخدمها في الابليشن بتاعنا. الاجنده بتاعتي النهارده involving introduction, AFib ablation in brief, new sources of AFib ablation and finally take home message. زي ما احنا عارفين الايفيب is the most common cardiac arrhythmia in clinical practice زي ما الدكتور احمد وضح, leading to major healthcare burden, especially cost due to increased morbidity and mortality. Over time, AFib naturally progresses from initially paroxysmal to persistent, عشان كده ال value for early AFib ablation is profound. Observational long-term follow-up shows that AFib progression itself is associated with an increased risk of clinical adverse events زي admission for heart failure أو stroke. Consequently, there is a profound rationale for early treatment to prevent progression and improve clinical outcome as cornerstone for AFib management. من 20 سنة زي ما قال الدكتور أحمد, بعد ما هيساجير ابتدى الموضوع ده سنة 98, من سنة 2003 2004 بقى routine regular work especially in Europe and USA AFib ablation. To date, catheter ablation for AFib compared to antiarrhythmic therapy is associated with significant reduction in recurrent atrial arrhythmias, rehospitalization, and serious adverse events. Nowadays, radiofrequency ablation together with cryoablation are the most extended non-pharmacological techniques used in ablation for myocardial tissue for management of atrial fibrillation. However, point-by-point ablation during pulmonary venous isolation has been implicated as a source for AFib recurrence due to failure of line continuity. زي ما قلنا الكلام ده كان في الايرا القديمه اللي هي بنابليت بوينت باي بوينت. Moreover, radiofrequency ablation has certain drawbacks and complications including tissue damage and clot formation. الجايد بتاعت 2020 بتاعت الاي سي سي for management of AFib patients stating that AFib catheter ablation after failure of drug therapy class 1 indication, first line therapy ranging from class 2A to class 2B. الراديو فريكونسي ابليشن ده هنا هوت الكونفنشنال ابليشن كاستر بتاعتنا واللاسو كاستر اللي هي المابنج in order to produce such lines by point with the opportunity to having gaps in between these points, so AF recurrence is high likelihood. ده هنا هوت histological lesions بتاعتنا اللي هي produced by radio frequency ablation conventional. Such ablation obviates the need for antiarrhythmic and anticoagulant drugs. Radiofrequency ablation is based on producing thermal damage to a region of tissue as a consequence of focal joule delivery by the passage of alternating electrical currents. Such heating is typically induced by delivering electrical currents through electrodes mounted on the catheter tips with frequency around 500 kHz. To control heating, radiofrequency ablation system depends on three mechanisms: either temperature, constant temperature, constant power, or constant voltage. The last two strategies, اللي هو constant power or constant temperature, are the most widely used strategies during cardiac ablation. When radio frequency ablation is applied to cardiac tissue, certain potential complications must be considered, زي formation of thrombi due to blood coagulation at temperature above 7 degrees, which can increase the risk for stroke. Also, with temperature above 100 centigrade, water in blood or in tissues changes from the liquid state to gas state, the so-called steam bumps with intramyocardial gas formation and local mechanical damage and distal problems, especially cerebrovascular strokes. Other potential complications, some of them are fatal for patients, especially damage to adjacent structures such as atrioesophageal fistula, internal bleeding, or damage to adjacent nerves. To minimize the risk of such complications when using radiofrequency ablation, in recent years, some other novel cardiac ablation techniques have been developed for the treatment of AFib. Cryoablation nowadays is widely accepted and used as an ablation source for isolation of the pulmonary venous ostia. Some new techniques are growing up, such as laser ablation and high-intensity focused ultrasound ablation. الراديوفريكونسي بالون كاثيتر ابليشن ده الهيليو كاثيتر بتاعت البايوسينس ويبستر، اعتقد مش موجوده في مصر، دي مش كده؟ ديت من بايوسينس ويبستر، ديت الديزاين بتاعها هاي تورك شافت فولود باي ديفليكتبل سيجمنت اند فاينلي البالون الابليتنج بالون كاثيتر with 10 electrodes mounted on its tip, gold electrodes mounted on its tip. دي study منشوره سنه 2023 من بلجيكا عن pulmonary venous isolation using radio frequency balloon catheter. It involved more than 100 patients with either paroxysmal in 14% and the rest are persistent AFib. The mean age around 65 years old. Mean Shad's FASC score بتاعهم كان 2.5. The study endpoint included any major periprocedural complications including this, atrioesophageal fistula, stroke, transient ischemic attack, pericardial effusion or tamponade with and without surgical treatment, myocardial infarction and persistent phrenic nerve palsy occurring within 7 days post-procedure. ده هنا هوت الجرافيكال ابستراكت بتاعت الستادي ديت showing that the safety regarding major complication almost zero complication except for cardiac tamponade in 1%, minor complication about 1% regarding femoral pseudoaneurysm, pericarditis. Also, here is the complete isolation for the pulmonary venous ostia as the voltage map post-ablation shows. In conclusion, a large cohort of patients undergoing pulmonary venous isolation with the radiofrequency balloon catheter, the complication rate is as low as 1%. At midterm follow-up, about 10 months, freedom from atrial tachycardia recurrence was more than 80%. Impedance drop and temperature rise are a useful predictor for persistent single-shot pulmonary venous isolation. البلسد فيلد ابليشن مش هتكلم فيه كتير لان هو المفروض التوك اللي بعدي عنها. Pulsed field ablation has been developed over the last years as a novel electrical ablation technique for treating many cardiac arrhythmias. The use of pulsed field ablation to ablate soft tissues was first proposed in 2005. It is based on irreversible electroporation, non-thermal phenomena, non-harmful to the extracellular matrix. So BFA is considered to be safer than the reference technique اللي هو radiofrequency ablation. Its mechanism of action is thought to be predominantly based on irreversible electroporation with a very low risk of thermal damage. The technique consists of in subjecting the tissue for brief high voltage electric field exposure. Electroporation is a biophysical phenomena in which the cell membrane permeability increases suddenly when the cell is exposed to electric field of high intensity exceeding certain threshold for short duration. If the cell membrane restores its integrity, the cell survives and the phenomenon is called reversible electroporation. However, if the electrical field exceeds certain threshold, electroporation causes permanent cell damage and the phenomenon is termed irreversible electroporation. It is called non-thermal irreversible electroporation in nitro, since the increase in the temperature produced during ablation as a result for joule heating is very low and it's not the mechanism by which the cell dies. The thermal effect produced by radiofrequency ablation are tried to be minimized in pulsed field ablation to avoid possible complications. It has shown promising results in terms for reducing the risk for injury to collateral tissues زي الphrenic nerve and most critically esophagus or avoiding other commonly observed effect in radiofrequency ablation such as pulmonary venous isolation, stenosis. Recent trials involving such technique demonstrate that it is associated with less muscle contraction and almost no pain sensation. دي حاجة منشورة في 2022 computational comparison of radiofrequency and pulsed field ablation. The objective of this study is to offer comparison for the morphology of the lesion produced by both techniques based on computational models. The study evaluates the effect of certain parameters that are specific for the case of the case for cardiac chamber, such as blood velocity and its cooling effect or the catheter direction. Conclusion بتاعها by means for computational models, the study compared radiofrequency ablation with pulsed field ablation in endocardial catheter ablation. Monopolar and bipolar catheter configuration were assessed under the assumption of blood flow. The simulation results indicate the substantial difference in terms for lesion morphology between radiofrequency ablation and pulsed field ablation are to be expected. Both for monopolar and bipolar configurations, for the same lesion depths, the simulations predicted that BFA lesions are wider, occupying bigger volume than those obtained by radiofrequency ablation. Also, RFA lesions display a much more asymmetrical morphology compared with that obtained with BFA. Simulated BFA treatments indicate that the risk for collateral thermal damage is very low but not zero, suggesting that this issue should be taken in consideration when designing BFA catheters and pulsing protocols. Finally, high power short duration ablation. In recent years, the high power short duration ablation strategy has been applied in treatment for AFib to produce continuous transmural lesions and limit collateral damage. AFib ablation using high power short duration generator settings was originally suggested in 2006. However, the definition of what constitutes high power shows considerable variability ranging from 50 to 90 watts. Previous studies have indicated that the application of HBSD strategy in AFib ablation procedure is associated with shorter duration time, shorter ablation duration, higher first pass pulmonary venous isolation, reduced risk for acute and chronic pulmonary venous reconnection, and low risk for AFib recurrence after single ablation procedure. دي الترايلز اللي هي discussing this issue regarding الباور study now number of patients main findings. The novel smart touch surround flow catheter designed with 56 small bore holes homogeneously distributed around the entire electrode surface to lower the electrode tissue interface temperature, increase the delivery of radiofrequency energy to the tissue and reduce the risk for thrombus formation. Additionally, the total RF energy delivery time is shortened during AFib ablation procedure using HBSD technique. Finally, take-home message. AFib remains a great challenge to healthcare providers with integrated complex management strategies. Pulmonary venous isolation is an effective treatment modality for AFib patients, reducing the risk for stroke and alleviating the need for anticoagulant. Finally, radiofrequency ablation technique is about to be outdated and it's well substituted by cryoablation, BFA, and HBSD ablation strategies. شكرا.
Slides, please.
Not yet.
Not yet? Okay, strange. Oh, sorry, I need to share them. So let me see here.
Share screen, please.
Yes. What about now?
Not yet.
Strange. Ah.
Yes. Just we need full screen. Excellent. Now it is okay.
Okay. So thank you for your patience, and thank you for your kind invitation. It's a real pleasure to be today here with you. So now my turn is to discuss about PFA and other energy sources in AFib ablation. This was already introduced by the previous speaker. Okay, so I'm going to give you a different perspective. These are my conflicts of interest. So let's start with PFA. As you know, this, as mentioned before, this is called also electroporation, and is based in rapid ultra rapid electrical fields that result in nanoscopic pores in the cellular membrane, leading to cellular death. The interesting aspect of this new energy is that there is a different tissue sensitivity. So this is low for blood vessels and nerve fibers, which are very resistant, and is quite high for cardiomyocytes. So this means that differently to thermal ablation, in which we can produce collateral organ damage to the phrenic nerve, to the esophagus, with PFA, you spare this damage, this potential damage. There are different devices already marketed. This is the Farapulse device from Boston Scientific. There is the one with more experience so far. There is a multi-spline catheter that needs to be positioned in the PV ostia. And then more recently, the Affera device from Medtronic has been also marketed, and there are many others coming soon. The initial results were published by the group of Viver Reyes and Tanego, and what was more interesting is that the procedure can be done in a very short time, roughly 1.5 and half an hour of left atrial dual time. Some few months ago, during the ESC Congress in September, it was published and presented this trial, this important trial, the VENT trial, which compared thermal ablation with cryo and RF versus pulse field ablation. And here you can see the results. In terms of procedural time, you see a significant reduction of roughly 15 to 20 minutes. And in terms of fluoroscopic time, it was the opposite. More fluoroscopy was needed. But in long-term results, the fact is that there were no differences. So it's clear that with PFA you can shorten the duration of the procedure, although in terms of results it looks similar to thermal ablation. So supporting the idea that the important thing is to achieve PVI independently of the energy that you use. One aspect that is more recently brought up is what are the potential implications of using PFA. And this is one of the 3 recent papers published about this that was trying to estimate what is the amount of tissue destroyed by PFA compared to radiofrequency, for example. And you see in this slide how the amount of troponin detected after the procedure is roughly 10 times higher with PFA. This is something that we knew from a long time when electroporation started at the beginning or close to 20 years ago, that the problem with electroporation is that you create a massive destruction of tissue. So this is something that for sure we'll need to clarify in the next years. Okay, so this was about PFA. What about other techniques? The most obvious is RF. This has been already also introduced by the previous speaker. And what this is new is high power short duration. We know that radio frequency heating is a result of two components, resistive heating, and from the core of this resistive heating there is a second heating that is conductive one. With high power short duration, the conductive component is tried to be minimized in order to avoid collateral organ damage. With this in mind, we conducted a large randomized multi-center trial. It's the largest so far, that was presented last year in the ERA Congress. We enrolled over 300 patients in 12 centers who were randomized to conventional RF ablation guided with contact indices versus high power short duration using 70 watts for 9 seconds. Here you see the follow-up. Patients were followed 1 year, and you see that at long term there were no differences in terms of atrial fibrillation recurrences. However, in terms of complications, there were no differences, but importantly, we detected a significant trend towards more stroke in the high power short duration arm. This was also confirmed with a sub-study of this multi-center trial that included patients with MRI, and we found a significant number of subclinical stroke in the high power short duration arm. So there are ways to try to minimize this problem. One is with this catheter, there is the diamond 10 that is using a special design with diamond rather than platinum that has the advantage that can diffuse thermal or heat much more than the standard materials, platinum, but also gold or steel. So it's a potential way that may influence what I have told you about emboli. There are other catheters in the market that are also new for RF application that have been already commented by the previous speaker. However, the information is quite limited so far. Other energy sources, what about cryo? What is new in cryo? And what is new is the ultra low temperature cryo. This is one of the catheters that is being produced. It can adopt different shapes, and this has been used for PVI. Here you see the catheter in our lab, and you see how fast and how powerful cryo energy is delivered. So you need to be careful because it's quite the low temperature. So you see my fingers attached to the catheter. This has been studied in the CryoCure trial. It was a non-controlled trial, and you see that efficacy at 1 year was quite high both for paroxysmal and persistent AFib patients. What else about cryo? There is a new study coming soon that is combining cryotherapy with PFA. This has some potential advantages, like reducing air formation, microbubbles, but still this is quite early to know if this is the way to go. So to finalize my talk, some take-home messages. PFA is a promising energy with control results published so far, but still there are some open questions. It's faster, yes, but what about efficacy? Is more successful? This is unclear nowadays. What about transmurality? What about contact dependence? And especially, what about lesion volume? Maybe we are doing too much. RF high power short duration, according to our results, similar efficacy and safety in terms of esophageal damage and tamponade, However, there is some concerns about a higher embolic risk. And finally, cryo, ultra-low temperature, promising results, but still they need to be validated in randomized clinical trials, and there is some hopes of optimizing this therapy with the combination with PFA, cryo-PFA. Nothing else, just to remind you the upcoming ERA Congress in April in Berlin, so you are welcome to attend the Congress. Thank you for attention.
Thank you very much, Dr. Marino. Very up-to-date technology. How many centers in Europe can afford to buy these catheters and use it?
Yeah, it's a good question. The fact is that, for example, in Europe, reuse of catheter is forbidden, so we cannot use, although there are new regulations coming allowing some kind of reusing, but under certain conditions, in order to fight about climate change and to have green policies. So at present stage, we are not reusing catheters, meaning that at the end of the day, there is an increase in cost, but it's not significant because we are already paying a lot for our regular catheters. And this is why PFA is quickly adopted in many centers in Europe.
Very good.
Thank you very much for the talk, Dr. Marino. Just a quick technical question about the results of ADVENT trial. As you shown, the outcome was similar between the three ablation technologies, the cryo, RF, and PFA, which is somehow surprising considering the presumed selectivity of PFA, because we were taught early during our training that ganglia ablation is important for elimination of atrial fibrillation, and one of the mechanisms by which ablation in the ostia or the antrum reduces AF recurrences by attacking the ganglia. So seeing similar results in a way raised the question of whether PFA energy is as selective as we thought on ganglia, or is ganglia as important as we thought they are. So do you have any comment about this?
Yes, very good question, very good comment. I think that there are several aspects in your question. First is the role of ganglia ablation. This is a speculation that has been never demonstrated. In fact, there are several trials trying to ablate or treat the ganglia and with neutral effects. So it's more a speculation rather than a true or a clear endpoint for ablation. This is number one. Number two is that we need to distinguish between paroxysmal and persistent AFib. In paroxysmal, the main driver or the main substrate is the trigger, and most of the triggers are coming from the PVs. So whenever you do a good job in pulmonary vein disconnection, you will have similar results. And this is why the ADVENT trial is showing the same effects. So you can achieve PVI with PFA, with cryo, or with RF. So the results will be exactly the same. Differences will be in terms of time, because PFA is faster, and maybe in complications, because there are different let's say, sensitivities and different effects of these energies in complications. But in efficacy, they look the same. Persistent AFib maybe is a different story, but still the data are quite scarce, and we'll see, because what is clear is that with PFA we create larger lesions. So we'll see, maybe using this energy in other left atrium parts. For example, there are people using PFA to isolate the left posterior wall of the left atrium. Maybe this will result in different success rate. We'll see.
Yeah, and there's also the question of transmurality and whether PFA can safely reach the epicardium, and whether that, I think these are also questions to be answered. Thank you very much.
Yes, it's a good question about transhumanity, and maybe because we are also thinking about PFA as a whole, but the PFA is coming with different catheters. Maybe they are not all the same, and with different energy in wave shapes, because you can define the wave in different, for example, unipolar, biphasic, so probably not all are the same.
Thank you very much. Thank you very much, sir.